أبنائي وبناتي الدارسين للجراحة العامة. This is Dr. Baki, Professor of General Surgery from Egypt. بنستكمل مع بعض مراجعة البنكرياس عن طريق ال MCQ, and this video is number 2. About anatomy of the pancreas, all of the following statements are true except it receives blood supply from the celiac trunk and from the superior-mesenteric artery, which is true. This is the celiac trunk. And this is the superior-mesenteric artery. Celiac trunk will give common hepatic artery, which will give gastroduodenal artery. From the gastroduodenal artery, we will have superior pancreatico-duodenal artery, which will supply the duodenum and the head of the pancreas. And from the superior-mesenteric artery, we will have the inferior pancreatico-duodenal artery. Okay? So this statement is true. Celiac trunk and superior mesenteric artery both contribute to blood supply of the pancreas. The pancreatic body and tail are supplied by the splenic artery, which is true. Here is the splenic artery. It supplies the pancreatic body and tail. The superior pancreatico-duodenal artery is a branch of the superior mesenteric artery. This is wrong. This is untrue. This is the exception. As a matter of fact, superior pancreatico-duodenal artery is a branch of gastroduodenal artery, which is a branch of the common hepatic artery arising from the celiac trunk. Okay? So this statement is, the exception is untrue. The lower end of the common bile duct is embedded in the head of the pancreas, which is true. مدفونة lower end of the common bile duct في الhead of the pancreas قبل ما تصب في second part duodenum in its posteromedial aspect. والمنظر ده منظر البنكرياس بتاعك لو انت بتبص عليه من ورا. تلاحظ ان lower end of the common bile duct embedded in the head of the pancreas. وتلاحظ at the neck the splenic vein is going to join the superior-mesenteric vein to form the portal vein. وتلاحظ ان superior-mesenteric vein and artery run in front of the uncinate process of the pancreas. Okay? The superior-mesenteric vessels pass in front of the uncinate process. That is true. So in this question, the exception or the untrue statement is C. The superior pancreatico-duodenal artery is a branch of the gastroduodenal artery, not from the superior mesenteric artery. Okay? About anatomical relation of the pancreas, all of the following statements are true except the lesser sac separates the pancreas from the posterior surface of the stomach. That's true. This is the stomach. If we elevate the stomach and the greater omentum, we will find in the stomach bed the pancreas. In this area, there is a potential space called lesser sac, and this lesser sac is going to separate the pancreas from the posterior surface of the stomach. The inferior vena cava lies posterior to the head of the pancreas. That's true. This is the head of the pancreas and this is the inferior vena cava. The portal vein is formed behind the neck of the pancreas. That's true. This is the neck of the pancreas. This is the splenic vein is going to join the superior mesenteric vein behind the neck of the pancreas to form the portal vein. The abdominal aorta lies posterior to the body of the pancreas. That's true. This is the body of the pancreas and this is the abdominal aorta. A splenic artery runs horizontally posterior to the body and tail of the pancreas. This is untrue. This is the exception. This is untrue. Why? As a matter of fact, what runs posterior to the body and the tail is the splenic vein, not the splenic artery. The splenic artery runs at the upper border of the pancreas, making a tortuous or zigzag course before reaching the spleen. So the splenic vein is posterior to the body and the tail. The splenic artery is at the upper border of the pancreas. Okay, go for E. About pancreatic physiology, all of the following statements are true except islets of Langerhans are concentrated in the left half of the pancreas. That's true. The protein digesting enzyme of the pancreas are normally activated in the intestine. That's true. Beta cell secretes insulin. That's true. Alpha cell secretes gastrin. This is untrue. As a matter of fact, alpha cell secretes glucagon. This is a drawing of the histology of the pancreas. This is the islets of Langerhans, consisting of mostly of beta cells, which secretes insulin, and alpha cells in the periphery of the islets, which secretes glucagon, and delta cells, which secretes somatostatin, and gamma cells, which secretes pancreatic polypeptide. And surrounding these islets of Langerhans, we have the acini of the pancreas, which secretes the enzymes of the pancreas or the exocrine part of the gland. Trypsinogen and lipase and amylase are going to be excreted into pancreatic duct. This is the exocrine part. And the islets of Langerhans will going to secrete directly inside the blood capillaries. This is the endocrine part. Okay? The commonest cause of acute pancreatitis is biliary stones or alcohol or hyperlipidemia or steroid therapy or hyperparathyroidism. We came across this question before. As a matter of fact, the most common cause of acute pancreatitis is biliary stones, gallstones. And to remember the causes of acute pancreatitis, you have the famous mnemonic I get smashed. Smashed, تخيل ان somebody smashed your pancreas, you will get pancreatitis. Who is going to smash I get smash? I for idiopathic pancreatitis. Some cases are idiopathic. G for gallstones, which is the most common cause of acute pancreatitis. E for ethanol, alcohol, second common cause of acute pancreatitis. T for trauma. S smashed, S for steroids, M for mumps, and A for autoimmune, S for scorpion bite, H for hypercalcemia and hyperlipidemia, E for ERCB, and D for drugs. I get smashed. Okay? All of the following are causes of acute pancreatitis except hypercalcemia, hypokalemia, hyperlipidemia, common bile duct stones, and thiazide diuretics. All are causes of acute pancreatitis except hypokalemia. Go for B. Okay? The following are features of acute pancreatitis except severe epigastric pain, that's true. Vomiting, repeated and severe vomiting, that's true. Shock state, that's true. Severe epigastric tenderness, that is not true. This is the exception. Go for D. Why? Pancreas is a retroperitoneal structure away from the abdominal wall. When there is severe pancreatitis, you will get just tenderness on mild tenderness on deep palpation of the epigastrium. But severe epigastric tenderness is not a common feature of acute pancreatitis. Go for D. Markedly elevated serum amylase, that's true. This is the most famous biochemical lab test we ask for when we suspect acute pancreatitis. Okay? So the exception here is severe epigastric tenderness. Okay? The commonest cause of death during the first week of acute pancreatitis is hemorrhagic shock or multiple organ failure or ruptured splenic artery aneurysm or pancreatic abscess or pulmonary embolism. As a matter of fact, the most common cause of death during the first week of acute pancreatitis is multiple organ failure. Go for B. Especially respiratory failure, especially acute respiratory distress syndrome as a complication of acute pancreatitis and acute renal failure. These are the most common cause of death during the first week. After the first week, the most common cause of death is sepsis. But during the first week of acute pancreatitis, expect organ failure as the cause of death. Okay? About acute pancreatitis, all the following statements are true except the aim of assessing severity is to select patients who require admission to the ICU. That's true. When you first encounter a case of acute pancreatitis, you should make some assessment to predict if this case is a mild attack or a severe attack, because severe attack should be admitted in the ICU. Urgent laparotomy is indicated for severe acute pancreatitis. This is the exception. This is untrue. Go for B, because as a matter of fact, the majority of cases of acute pancreatitis are treated medically, conservatively. Very few cases or very small subset of patients of acute pancreatitis will be treated surgically. This is untrue statement. Age above 55 years is considered a bad prognostic factor. That is true. Hypocalcemia is considered a bad prognostic factor. That's true. Obesity is considered a bad prognostic factor. That's true. In acute pancreatitis, about 90% of cases are going to be mild acute pancreatitis. And this mild 90%, only mortality you will get less than 1%. From 5 to 10% of acute pancreatitis is going to be severe necrotizing pancreatitis. And of those 10%, you will have 40 getting infected necrosis. Of those people of infected necrosis, the mortality is going to be about 20%. Okay? So in general, of all cases of acute pancreatitis, you have around 10% mortality. That's why it is not, should be taken lightly. It is a serious disease. Okay? About conservative treatment of acute pancreatitis, all of the following statements are true except severe acute pancreatitis cases require treatment in an ICU. That's true. Circulatory support may require blood transfusion. That's true. Mechanical ventilation is indicated when arterial PO2 is less than 60. That's true. Intravenous antibiotics may reduce infection of necrotic pancreatic tissue. That's true. ERCP for sphincterotomy and for removal of bile duct stone is indicated for all cases. That is untrue. This is the exception. Go for E, because ERCP is done for biliary pancreatitis only when there is impacted stone at the lower end of the common bile duct, causing bile to regurgitate into the pancreas and activating pancreatic enzymes, causing autodigestion of the pancreas. Only in these cases we go for ERCP, not for all cases. Okay, this is the exception. About pancreatic pseudocyst, all the following statements are true except pseudocyst may be painless. That is true. A large cyst is felt in the epigastrium. That is true. It shows transmitted pulsation. That's true, from the lying aorta, because it lies in front of the aorta, so it can transmit the pulsation. The best imaging study for the diagnosis is barium meal. This is untrue. This is the exception. Go for D, because as a matter of fact, nowadays we don't ask for barium meal, we ask for ultrasonography or CT. This is a picture in CT of a huge pseudopancreatic cyst compressing and obstructing partially the stomach, in front of it. Okay, this is the axial view and this is the coronal view of a huge pseudopancreatic cyst. In the past, we will do barium meal and we will take a lateral view showing the stomach compressed in such a way because of this pseudopancreatic cyst lying in the lesser sac. But nowadays we will ask for ultrasonography and CT. So go for D as exception, alright? Surgery is done for cysts that persist for more than 6 weeks. That's true. For pseudopancreatic cyst, avoid intervention before 6 weeks because after 6 weeks you will get a tough wall of the granulation tissue, wall of the cyst. You can make a window between the cyst and the posterior wall of the stomach to drain this cyst. And this window, after 6 weeks, the wall is tough enough to hold your suture. Before 6 weeks, it will not hold your suture. And if you wait for 6 weeks, about 70% of the cyst will resolve spontaneously and you will need no drainage. So we have to wait for 6 weeks for the granulation tissue to be tough enough to hold suture. And in the past, we will do surgery to make a window between the posterior wall of the stomach and the cyst to drain the cyst. Nowadays, we do it endoscopically. By endoscopic ultrasonography, we can make this window. Okay? Complications of acute pancreatitis include all of the following except respiratory failure. Yes, that's true. Renal failure. That's true. Hypercalcemia. This is untrue. Go for C. As a matter of fact, acute pancreatitis will cause hypocalcemia. Why? Because lipase acting on the fat will cause lysis of fat into glycerol and fatty acid. Fatty acid will combine with calcium of the blood to make this chalk spots in the peritoneal cavity when you open this patient. And this is a necrotic pancreatic tissue, this black tissue, okay? So, acute pancreatitis will cause hypo, not hypercalcemia. It causes pancreatic pseudocyst, that's true. It causes pancreatic abscess, that's true. So, go for C. About the diagnosis of acute pancreatitis, all of the following statements are true except serum amylase is markedly elevated during the first week of the attack. This is untrue. This is false statement. As a matter of fact, serum amylase will be elevated within hours of the attack and will disappear within 2 or 3 days because it have a short half life. But what remains elevated is serum lipase. Serum lipase will be elevated within hours and will remain elevated for 1 or 2 weeks. But serum amylase will be elevated for 2 or 3, maximally 4 days. Okay? This statement is wrong. The rest will be true. Low arterial PO2 is expected in severe cases. That is true. Hypoproteinemia is expected in severe cases. That is true. Dilated common bile duct on ultrasound examination suggests a stone impacted in the lower end. That's true. CT scan with intravenous contrast can help staging the severity of the disease. That's true. About clinical feature of chronic pancreatitis. Beware, chronic, not acute. All the following statements are true except chronic abdominal pain is the main symptom of chronic pancreatitis. That's true. The disease can cause chronic constipation. This is untrue because in chronic pancreatitis there is deficiency of lipase and fat will go undigested in stool causing steatorrhea, the opposite of constipation. So this statement is untrue. Others will be true. The disease can cause loss of weight. That's true. Chronic pancreatitis can cause diabetes mellitus, that's true. The disease may cause obstructive jaundice, that's true. Sometimes chronic pancreatitis can compress the common bile duct and cause obstructive jaundice. Okay? So, the untrue statement here is B. About management of chronic pancreatitis, all of the following statements are true except fecal fat stimulation can assess exocrine function of the pancreas. That's true. Secretin stimulation test can assess exocrine function of the pancreas. That's true. Surgery is required for the majority of chronic pancreatitis patients. This is untrue. As a matter of fact, surgery is required in a minority of patients. Okay, those with intractable pain and dilated duct may benefit from surgery. So go for C. ERCP is done if surgery is indicated. That's true. Pancreaticojejunostomy is visible only if part of the pancreatic duct is dilated. That's true. The most common site for carcinoma of the pancreas is the head of the pancreas. 60 to 70% of carcinoma of the pancreas will occur in the head. Okay? About spread of pancreatic head cancer, all of the following statements are true. Invasion of the common bile duct causes obstructive jaundice. That's true. Direct infiltration of the superior mesenteric artery indicate inoperability. That's true. Lymphatic spread can reach lymph nodes along the hepatic artery. That's true. The first station for hematogenous spread is the lungs. This is untrue. This is untrue. Go for D because the venous blood of the pancreas go to the portal vein, go to the liver. The liver is going to be the first station, not the lung. Okay? Go for D. Transperitoneal spread can cause peritoneal nodules and ascites. That's true. Cancer of the head of the pancreas has the following clinical feature except progressive jaundice. That's true. Severe abdominal pain. No. This is the exception. This is untrue. As a matter of fact, obstructive jaundice of carcinoma of the head of the pancreas initially painless. There is no marked pain in malignant obstructive jaundice due to carcinoma of the head of the pancreas. Tea-colored urine, that's true. Itching, that's true, and may be very distressing. Okay? Usually a palpable distended gallbladder, that's true. What is called Courvoisier law. Okay? About the diagnosis of suspected carcinoma of the head of the pancreas, all of the following statements are true except the tumor marker of pancreatic cancer is CA19-9, that's true. Trivesic CT scan shows cancer as an enhancing lesion. This is untrue. This is the exception. As a matter of fact, when we do triphasic CT, the pancreatic head carcinoma shows hypo-dense in relation to the pancreas, not enhancing. It doesn't enhance. The surrounding pancreas enhance, but this is the carcinoma is not enhancing. This is another picture of carcinoma of the head of the pancreas not enhancing during triphasic CT scan. Okay? The pancreas is enhanced by the dye, but the carcinoma is not enhanced. Alright? Ultrasound of the abdomen is less likely to see the tumor than CT scan. That's true. Ultrasound of the abdomen shows dilatation of intra and extrahepatic bile ducts. That's true. Alkaline phosphatase is expected to be elevated. That's true. With operation for obstructive jaundice, the patients are particularly prone to develop any of the following complications except لما بتعمل عملية على بني آدم عنده obstructive jaundice هو بيبقى risk for what? Risk for pulmonary embolism? No, this is the exception. As a matter of fact, no increased incidence of DVT and pulmonary embolism when you operate on a patient with obstructive jaundice. The rest will be true. You might be faced with excessive bleeding. That's true. Septicemia might take place. That's true. Postoperative renal failure and liver failure may take place. That's true. But pulmonary embolism is not a high risk when you operate on a patient with obstructive jaundice. Regarding treatment of pancreatic head cancer, all of the following statements are true except for an unresectable tumor, the best treatment is radiotherapy. This is untrue. This is the exception. As a matter of fact, for a resectable tumor, the most common palliative procedure is to do cholecystogegnostomy, okay, to bypass the obstruction caused by the tumor in the head of the pancreas. So go for A. The rest will be true. Pancreatic duodenectomy operation is indicated for early cases. That's true. In a Whipple operation, the superior mesenteric vessels are spared. That's true. By the end of Whipple, there are gastrojejunal, hepatocojejunal, and pancreaticojejunal anastomosis. That's true. For patients who are not fit for anesthesia, endoscopic stenting is indicated. That's true. Regarding the prognosis of exocrine adenocarcinoma of the pancreas, all of the following statements are true except carcinoma of the head carries a better prognosis than carcinoma of the body and of the pancreas. That's true because carcinoma of the head early in the disease will obstruct the common bile duct, causing obstructive jaundice, attracting the attention of the patient to seek medical advice. Carcinoma of the body and the tail of the pancreas go unnoticed for a long period of time and causing non-specific loss of weight, loss of appetite, cachexia, and by the time it is discovered, it is very advanced, unlike carcinoma of the head of the pancreas. Periampullary carcinoma carries a better prognosis than carcinoma of the head proper. That's true, because periampullary carcinoma being very near to the ampulla of water, it will obstruct the ampulla of water, causing obstructive jaundice when it is very small in size. That's why it attracts the attention of the patient and his doctor to the problem. That's why it carries a better prognosis than carcinoma of the head proper. At laparotomy for head cancer, early cases that are suitable for pancreatic duodenectomy represent 10% only of the total. That's true. Invasion of the portal vein worsens the prognosis. That's true. Pancreatic duodenectomy Whipple operation is a minor palliative operation. This is untrue. As a matter of fact, Whipple operation is a very major operation. It takes not less than 3 hours. And it has less than 1%. As a matter of fact, it has at least 10% operative mortality. So this statement is untrue. This is the exception. Whipple operation is a major operation with operative mortality around 10%, not 1%. Okay. About insulinoma, all of the following treatment statements are true except it arises from the beta cell of cells of Langerhans. That is true. It usually arises from the head of the pancreas. This is untrue. This is the exception. As a matter of fact, it tends to arise from the area near the tail of the pancreas, not the head. This is the exception. This is untrue. It is usually benign. That's true. It gives symptoms of hypoglycemia. That's true. The best treatment is surgical resection. That's true. About the Lingard-Esing syndrome, all of the following statements are true except it may be part of type 2 of multiple endocrine neoplasia syndrome. This is untrue. This is the exception. As a matter of fact, the Lingard-Esing syndrome is a part of MEN 1, not MEN 2. MEN 1 consists of the 3B. B for pituitary adenoma, B for parathyroid hyperplasia, B for pancreatic tumor gastrinoma. So, the Lingard-Esing syndrome could be a part of MEN 1, sorry. MEN 2, you will remove pituitary adenoma of the main one, you will keep parathyroid hyperplasia, you will add medullary thyroid carcinoma and pheochromocytoma of the adrenal gland. This is main 2, main 2A. Main 2B, you will remove parathyroid hyperplasia and you will add mucosal neuroma and marfanoid feature together with medullary thyroid carcinoma and pheochromocytoma. Okay, so Zollinger-Ellison syndrome can be a part of main 1, not main 2. Okay, the rest will be true. Hypergastrinemia causes intractable peptic ulceration. That's true. The majority of gastrinoma are malignant. That's true. 60% of gastrinoma are going to be malignant. Diarrhea is present in 30% of cases. That's true. If tumor resection is not possible, an alternative is to do total gastrectomy. That's true. We do this in the past. But nowadays, instead of doing total gastrectomy, you can give proton pump inhibitor high dose 40 milligram twice daily. It will control the hyperacidity. No need to do total gastrectomy, okay? Thank you so much for watching this long video. This is Dr. Baki, Professor of General Surgery from Egypt. Now kindly like, share and subscribe.